Welcome everybody this afternoon to Numark's podcast. In terms of got some topics to discuss, I'd like to cover off Numark's 12 principles for the practice of community pharmacy, or looking ahead to that. I know, Anne, you've kindly written an article about prescribing. And Richard, we were out in Glasgow recently looking at prescribing in pharmacy. And Sadik, I'm sure in our own Numark magazine of this month, you feature heavily on the front page in your views on where community pharmacy could go. I'd probably like to start with the undergraduate piece you mentioned there, and how I think you described it as ripping up what the old course was and moving it in much more to an engaged programme. One with the community pharmacy network, and I know the managed sector as well in hospital. But really, could you give us a bit about the aspect of preparing our new graduates to be prescribers and the type of thing and the thinking behind that?
In 2021, that's when the prescribing came into the undergraduate degree, so that the new registrants are prescribers. But at Strathclyde, we'd kind of thought about that before. So when we had that huge revamp where we involved all our stakeholders in what they thought our degree needed to be, and then we made that happen within the university regulations, we were already starting in 2010, 2011, looking forward to what does a pharmacist in 2025-26 need to know, which is very different to what, well, three of us have just admitted that we're graduates from the 80s, what we needed to know and what we were taught then. And we not only moved the focus from what does the pharmacist need to know, but to what does the student need to learn, so that it wasn't about us teaching them, it was about them finding out things. And we rearranged our degree so that it was very systems focused, so that the students were learning the chemistry, the pharmacology, the pharmaceutics, alongside all the disease processes, so that they were much more understanding why that was needed to treat that disease. So keeping that underpinning science, but increasing the amount of practice they get and the amount of patient focused. So a lot of our learning relates then to patient scenarios and what would you do, what would you prescribe, why would you prescribe it, and what's the science that underpins that, so that they're a nice, well-rounded pharmacist coming out.
Thanks, Anne. Richard, it'd be good to hear from yourself about your experience, in Glasgow, and what you saw in terms of a prescribing environment.
We talked to about 4 or 5 prescribers during our visit in 3 pharmacies at various stages of their career, actually. But what I thought was the impression I got was how central, even routine prescribing had become in their practice. It was almost as if, well, you've come all the way up here to see us do our jobs. This is what we do now. And I was really struck by that. And it was really apparent to me how rewarding the pharmacists that I spoke to found prescribing, and found using their skills to the benefit of patients. Now, mostly with Pharmacy First Plus, which is the national service in Scotland for common clinical conditions. Pharmacy First Plus service, I think, launched about 3 years ago, and it's become very central to not only pharmacy practice, but the way that the system works in Scotland, and the number of pharmacist prescribers, increasing all the time. And so it's only going to become more familiar to patients and more plugged into the system. There was a quote, and I think it was, we went to see Alistair McIntyre, didn't we, from Burnside Pharmacy, and he said straight away to me and to us, he said something like, I'm kind of paraphrasing here, I see the place, where I practice as a pharmacist as the consulting room, not the dispensary. And to me, that was a really striking comment. And 90% of our coverage, I'd say, probably maybe 80 to 90% of our coverage concerns pharmacy in England. And I reckon 80 to 90% of our community pharmacist readers in England wouldn't be saying that comment. So I was really struck by that. And I was also, it was very apparent how quickly the policy framework is developing in Scotland, and how the system has kind of identified gaps that it saw pharmacists playing an important role in using prescribing with common clinical conditions. So it's a system-led approach, whereas in England, we seem to be taking the opposite approach, really. We're making all our graduates prescribers, and we're doing a lot of kind of backfill training for existing registrants so they can gain their prescribing qualifications. And, you know, notwithstanding that the Pathfinder program, it's a case of, well, no, what are we going to do with them now? It's completely different. And I find the clarity of policy and the direction of travel much clearer in the Celtic nations than in England.
Great. Thanks, Richard. And so, Sadik, you've heard that view from undergraduate training and getting people ready. You've heard Richard's experience of how that's being deployed. It'd be really nice to hear your own views around how you think that could be fitted into policy.
Richard is right. You know, there isn't a framework or role for the prescribers that we're producing in England yet that's been, you know, put there. But what I disagree with Richard on, in a kind of controversial statement, so to speak, is the idea that it's good for pharmacists to fill the gaps in the health system as a profession. We are not carving out a niche for ourselves as a profession. We are filling the gaps left by others. And that is not a safe professional space for the future of pharmacy. We are not cheap doctors or expensive nurses. And the systems that are being built, and we have the greatest envy for Scotland and Wales when we look in pharmacy in England. The systems that are being built on the principle of pharmacists going where they're needed to fill the gaps, as Richard said. And that is not a sustainable long-term place for the profession to be. We need to look at where probably our professional boundaries lie, and, you know, where our profession should be going. What do we want to be? Because pharmacy is constantly done too. And I repeat this frequently, so frequently it feels like it rolls off my tongue, because we don't take ownership of the direction of travel for the profession. The idea that we know what we want as a profession is quite, ridiculous, because there is so many different chunks of the profession that want different things, and so many people understand a different thing by the term pharmacist. Mm-hmm. So we need to come to terms with where we need to go to be able to write that future. And you can see it's apparent in England when we talk about a community pharmacy prescribing service, say in a manifesto. But what does that practically mean? I know it refers to a white paper that mentioned it. I have a vision for what I think that might be, but probably people have various other views too. For me, it's back to this idea of professional boundaries. What do pharmacists do? Do we just supply medicines? Do we just ensure that we're a barrier of safety? Do we accuracy check? Do we clinically check? Do we give advice? Do we treat minor ailments, which again, kind of belittles our ability as a professional when we start calling what we do minor? Or are we the people who are responsible for medicines, which kind of sits us in the idea of we prescribe? GPs are experts on diagnosis.
Absolutely. Nurses
are experts in, carrying out the actual kind of clinical need of patients and, the care. And pharmacists, are the experts in prescribing. Yep. That's what I was taught at university.
We've had this discussion before that I would say a medical practitioner's primary function is to diagnose what's wrong with you. And currently their secondary function is therefore to prescribe. And I think pharmacy, particularly in the community, is moving into an area where its primary function will be to prescribe. And its secondary and important necessity to supply. But that takes us And I was struck by your view about the accuracy check. And I know, Anne, we've spoken about this before around how technology and technicians can deal with accuracy, and let the clinician, the pharmacist, deal with safety, which is linked and different. Because I think accuracy is about, have you given out the 28 Ramapro 5 milligrams that's been prescribed? And the safety is about, should you be getting 28 Ramapro 5? And it's that distinction for me.
We had that debate with a group of medical practitioners and pharmacists in the same room. And overwhelmingly it was, doctors, we know how to diagnose. We don't know everything about medicines that you do. We can work together with one diagnosing, one prescribing. And that would be just lovely if that happened. But for that to happen, we probably need an awful lot more pharmacists out there working much more closely with the medical practitioners to make sure that, as you said, Harry, everything is safe and the accuracy. We've moved on from having to count the tablets out of a big tub.
Indeed. Sadik?
So, I mean, 2 bits on there, and don't disagree with you at all. However, I would say possibly we might not get more pharmacists. We might get more professional roles from those in the team. So pharmacy technicians can take an even greater, because you've seen the strides in the last decade and a half as pharmacy technicians have taken their role and rightful place, as kind of guardians of safety in the team and accuracy.
I think it's a collective in that respect, and having people delivering particular roles in the pharmacy network is, I have to say, I've always championed that, even since my pre-reg year, I remember it, and having people actually doing the roles where they add the most value to the healthcare system. And Richard, maybe we move on. That we've had a chat there about prescribing, etc. And I know that one of the other pillars as we look to the 10-year plan is about prevention, if we could get into prevention earlier. What's your own thoughts there on the community pharmacy network playing a part in prevention?
The accessibility of the network is really, really important here. And I think it kind of, it follows on from what we've been saying, because if for community pharmacists, the present and the future must be about the safety of medicine supply, then that's got an absolutely key role of prevention, isn't it, to stop problems occurring in the future. And actually, if you look at where prescribing could go, and capitalising on the access of the network, if we move pharmacy towards providing, packages of care around medicine supply and optimizing medicine supply in all its kind of facets, then that's a key aspect of the prevention agenda.
I think we were both at an event yesterday about how vaccination is actually one of the prevention aspects, and how do we get considering antimicrobial resistance with that, as in assisting in reducing that, would be another area to go with. One of the other things to pick up on Sadik's earlier comments as well, when you mentioned about minor ailments and the word minor, fascinating, because literally this week I fed back to the team about not so sure about the word minor. Yeah, and I tend to use the phrase common clinical conditions.
So I think the terminology is really important, and I think I'm very careful now to say common clinical conditions.
And so, Anne, I'm going to come back to you in terms of undergraduates and things, and how things are moving on. We'll just talk there about the prevention agenda. Where do you see that fitting into an undergraduate programme as we go ahead?
So everything a pharmacist does is integral to our undergraduate programme. So prevention's in there as well. And it's one of our learning outcomes that the students have got to meet it. And thinking about how can you stop cardiovascular disease happening, for example? How can you stop respiratory disease happening? What are the factors that go behind that? And what can we as pharmacists do to help people not have diseases in their older ages? The simple one to think about is the smoking cessation campaigns. And how does that fit into making sure that people then don't go on to get respiratory and cardiovascular disease? But there's so many other things that happen in community pharmacy that fit with that you can go and see a pharmacist really easily. And I know we do lots of talking about prescribing, but we also need to think, how can the pharmacist be involved in stopping medicines that aren't needed? Because a lot of the problems that we get into is because you've been prescribed something and then you have something for those side effects and then something else. And if someone just took that holistic view of the patient, you could probably stop quite a few of the medicines that they're on. And how can a pharmacist build their role in that? Because they're the person that sees the patient probably more often than anybody else and sees these things. And the prevention of harm from medicines is also important.
Actually, Anna, I just see that as prescribing. I have to say, I'm not a fan of the terminology deprescribing. I just see it as appropriate prescribing.
It is all just prescribing, but there's a lot of people out there think the prescribing is putting your pen to paper and writing a prescription, adding something. And we've got to remember it's looking at your patient as a whole.
You know, by the time we get a patient, it's, you know, quite late down the road. For them. So actually, prevention agenda probably needs to start like some of the European countries with, you know, kind of prick tests, genetic screening, 100 conditions, make sure you've got the profile for the patient, their genome, slap it on the NHS spine so we can constantly add a live, you know, kind of test for new conditions that we kind of analyze their genome for, so that we can model, you know, earlier risks and behaviors that we need to adapt for that patient. That needs to be the beginning. But, you know, at that, we can only help the next generation. It's like I was on the tobacco and vapes bill from the, you know, 1st of January 2009. We hope to have a smoke-free generation. That helps them, but it doesn't help the people we've already got. So, you know, we also need to think about how we roll out that system of, you know, genomics, pharmacogenomics, and actually make the dream of pharmacogenomics, which again has existed for quite a while, a practical reality.
Yep, it's coming.
You know? So that's where I think the prevention agenda will really, you know, kind of come in, because at the moment we do a prevention agenda by blood pressure checking, but you know, actually it would be far better for a patient to know their cardiac risk based on genetics, their blood pressure risk based on genetics, their response to medicines based on genetics. We already have the information, we just don't hold it or use it, which, you know, feels like we're behind the times.
Let's take our conversation along that particular line, because if you take the pharmacogenetics and pharmacogenomics, as we would say, and how that will advance as we go along, it's going to require us to use technology, I suspect, better. It will need data and appropriate data feeds between professions and between citizens. You know, let's not say they're always patients, but the citizens who are going to access healthcare. So, Richard, what do you see, or would you agree that we need to be more adopting of some of these technologies?
I would say I think there's been a lot of progress made within the last 3 or 4 years with things like, you know, robotics. Now we're beginning to see kind of AI applications going into PMR systems. So I think at the moment, and you know, it's not before time either. There's a lot of focus, quite correctly, on the kind of processes and systems and creating efficiencies, because headroom is the big problem for community pharmacy at the moment. All these things we're talking about make absolute perfect sense to the health of the nation. The trouble is there isn't the capacity within the sector at the moment to deliver a lot of them, especially at the moment with external funding and workforce pressures. The aspect of technology that I'm really interested in at the moment, and it'll be really interesting to see where AI goes in all of this. And we've already got systems out there that are looking at streamlining clinical checks, for example. So these are big steps for pharmacy to take here, and challenging for the regulator as well. So let's see where that goes. Yeah,
certainly it's one of the Numark principles about, as I say, technology and its use and adoption and use of data to give us evidence so that we can target interventions better.
I do think there is a sufficient amount of help that can be provided to the system by, you know, so first of all, legislation. Hub and spoke model 1 makes a lot of sense. Model 2, I think, is apocalyptic, where, you know, it will have unintended consequences which could sufficiently damage the pharmacy network to make it unsustainable, because it would allow a level of competition we're not ready for, as an industry. So model one is where you can have separate hub and spokes providing, and you still have that link with the patient, which I think is essential for how the network operates now.
Yep.
But when you're looking at kind of AI, and I'm going to separate it out to machine learning, right? Mm-hmm. The differences being AI can have the same flaws that I can. I can be very convincing, and you could believe me, but I might not be right. But AI could believe that. And for machine learning, it's when big data will start to have unexpected side effects, or allow it to think something that is a small kind of problem is actually a valid solution, because the data is so large that it accepts it based on thresholds. So with those two models, both of which indicate the essential need for audit. So for me, all of the technological progress in pharmacy needs to be weighed up on the risk. There is definitely benefit for improving our processes and automation through machine learning and AI, but it has to be safeguarded with the right level of audit to keep us on track. But the GPHC is underpowered, it's under-resourced, and it has constantly held back its fees on reflection of the difficult circumstances the pharmacy has been in. And we need to remember, they're not there to help pharmacy as a profession. They're just there to protect patients, and they need the resources to do that. So for me, I think there is incredible opportunity for automation.
But say we adopt technology and we get our processes as efficient as they can be, this headspace that Richard has already mentioned will take us into the field of confidence and competence to then deploy them once that headspace has been created. So Anne, I'll come back to yourself about in this undergraduate aspect of what's being done from an educational perspective to equip our new registrants, the new entrants to the register, who to have the confidence to deploy these new skills that we're actually equipping them with.
So throughout their undergraduate degree, they're going out for their experiential learning, and that is so critical to the students being able to do. So when our students are on experiential learning, we don't want them just watching, we want them doing things under supervision, and we're bringing in the frameworks to make sure that they are competent and confident. But going back to the technology, they are so much more confident with the technology than we are. They've been brought up with all these new things. Having a robot dispensing, that's easy for them. That's nothing new and exciting. That's what they want to see all the time. And they want to have that time then freed up to put their clinical knowledge into practice. And what the practitioners at the moment need to do is be able to give our new graduates or new registrants in a year and a bit's time that support to be able to allow them to do what they've been educated to do, what they've been learning about all the way through their degree, to go out there and write those prescriptions. And I'm going to make a plea for another bit of technology. Can we please get to the point where the patient holds their medical record that every healthcare professional can access, rather than it being held away? It's a tool that the pharmacists need. And when we're working with the students, we're giving them all the bits of information they need to make these decisions. And then they're going out into practice and saying, I've maybe not got that. I maybe don't know what the blood pressure's been the last 3 times it's been monitored, or I don't know what their HbA1c is. I only have their blood sugar from today. So it's making sure that the prescribing decisions are safe. And I keep coming back to safety.
Richard, I'm going to give you a comment, and then I'll come to Sadik about that kind of access to records, safety, whatever, your own views on that.
I don't understand the politics of why not having access to an essential patient record on a card or whatever in this day and age. I don't understand why that is so difficult, because Anne's absolutely right. I mean, even doing something, as simple as pharmacy first kind of consultations and linking in with the record, you're not getting the full you're not getting full access. You're getting limited access. So you really are working with one hand behind your back.
If we had to pay £100 billion to have that system up and running, it isn't cost effective for the taxpayer. And so the taxpayer and the cost effectiveness of it dictates where that would sit in a priority queue. A rather simplistic explanation to the fact that pharmacy does have a slightly louder voice than its footprint. But, it is, for me, I think the system works very well for pharmacy, and I think it will work well for patients, but we haven't significantly demonstrated the benefit to the wider system.
Well, actually, in terms of technology, I think what we're talking about is not a lot of investment at all, Sadik. It's just connecting it up. And colleagues who are more technical minded than I am would tell me it's relatively simple to do for not a lot of investment. And it comes back to the safety point that I think I'm going to bring Anne back into. And actually, in terms of, for not a lot of money, we could make a big impact on public and citizen safety.
And Harry, that's exactly what I was going to say. It's about patient safety. Cost effectiveness, but what price do you then put on somebody's life of being able to prescribe absolutely safely with the information you need? And that might not be all the genomics now, that might be in the future, but even access to data on back blood pressures, HbA1cs, to make safe prescribing decisions. And I would say it's safety rather than cost effectiveness.
I'm conscious of the time, and it's been great to have the debate and the discussion. What I'd like to do is give you each the opportunity for a final and closing statement, and I'd like to hear your views, if you could, on your aspirations and hopes for the future, particularly in the community pharmacy setting.
I just think we're at such an exciting point for pharmacy at the moment, with all these new, enthusiastic, slightly scared graduates who will graduate from all the schools of pharmacy in less than 6 months, go on and do the foundation training, and then be these prescribers in 2026. And we need to harness their enthusiasm and skills to take pharmacy where it needs to be, with pharmacists as the point of prescribing, being those real experts in medicines on the high street that people can access easily. I see a hugely bright future for pharmacy, but we need to harness the enthusiasm.
Thanks, Anne. Richard, I'll come to yourself next.
I think the future of pharmacy and community pharmacy has never been brighter, actually, and the opportunities are becoming clearer. And in fact, a lot of the building blocks are already in place. And we've talked about applications of technology, clinical skills development through prescribing. We're looking at regulatory changes like supervision. All of these kind of things are putting the building blocks in place, for a much brighter future for community pharmacy. However, the day-to-day at the moment out there has never been tougher. And I know we're not good time to talk about funding situation, but it is pertinent. And until some of the external pressures are addressed, and we relieve some of the enormous pressure that the sector is under at the moment, then the danger is we don't realise that clinical future. And that's not only a tragedy for pharmacy, then that's a tragedy for our nations as a whole.
And Sadik, I'll give you second last comment. I'll sum up at the end. Yeah.
With the optimism we have, there is also the great risk we face. So things could, in 20 years' time, still be the same. And that is a tremendous risk we face as a profession and as a sector. We need to make sure that the teams that Anne is churning out have a great place to work, that they can fight for, help evolve, and make sure that the pharmacist's job is a great one.
So I think there's something, a piece of learning in that. As I say, the 12 principles that Numark have got for future of pharmacy practice address all of the areas that we've talked about today. If colleagues who listen to this haven't seen them, I would recommend you go on the net and have a quick look at them at Numark Net, or if anyone wants to see them, they're freely available if you contact myself. Can I just thank very much Anne, Sadik and Richard for your candid comments today, very much appreciated. So colleagues, thank you very much for your time today and your contributions. I'm sure we'll have these posted well with comments for people and colleagues to listen to, and thank you very much.